Hello friends, now we'll discuss about the some other drug which is also used in a angina pectoris, or we can say some newer agent. So the fourth drug which is used as an anti-anginal drug, that is the first drug is the dipyritamole, second drug is the trimetazidine, and the third drug is the ranolazine, and the last one is the ivabradine. So these four drugs have different types of mechanism, and it can lead to, or we can say finally result, it's helpful for the angina pectoris, or those persons suffering from angina. So let's talk about that how this drug is the help for the patient. So the first drug, that is the dipyritamole. Let's first talk about this drug. Actually this drug have one extra benefit, that this drug have anti-aggregatory effect. Obviously this drug also dilating the vessels, but along with the vessels this has also anti-aggregatory effect. So for the this drug is the, we can say, mostly helpful for the unstable angina, because in unstable angina the lot of platelet aggregate in the plaque area, and it can lead to the completely blockage of the lumen. But this drug is the nowadays we don't use as an anti-anginal drug. Why? Let's discuss. First of all, actually this drug is the, first of all, it's a increase the prostaglandin I2. Then that is the first effect. Second, it's also increase the adenosine. Then it's a decrease the thromboxane A2. So these three effects lead to anti-aggregatory effects, anti-aggregatory, and second one, dilation of vessels, or heart rate will be also decreased. So due to increase the prostaglandin I2, and this hormone, this hormone is the synthesis from every cells from the phospholipid. So we'll not discuss detail, just while you trust that this molecule is the disaggregate the platelets first. Second, the increase the adenosine. Actually due to increases the adenosine will be lead to dilation of the all blood vessels. We can say most probably it's artery smooth muscles relaxation, and lead to the dilation of the artery. Also it's act on the heart like SA node and AV node, and decrease the cardiac output. And then the thromboxane A2, due to the decreasing of the thromboxane A2, this also lead to, because the thromboxane A2, the function of the main function is the aggregation, and new platelet will come and aggregate in the inflammatory area. So the main function of the thromboxane A2, but by this drug it's inhibiting the thromboxane A2, so obviously it's lead to the decrease the platelet aggregation, or we can say disaggregate. So these three mechanism have dipyritamole. Adenosine, actually why, how it's increase the adenosine. So first it's decrease the reuptake of the, actually adenosine is a reuptake in the endothelial cell. So first it's a decrease the reuptake in endothelial cell. Second, it's also inhibit the, or we can say inhibit the degradation actually the adenosine deaminase, that is the enzyme. So by the help of this enzyme, the adenosine will be degrade, or we can say break down. So it also inhibit the degradation and decrease the reuptake of the endothelial cell, and they both can lead to the increase the adenosine, and it's start the own function. So this all information about the dipyritamole. But one bad thing about the dipyritamole, that's why we right now nowadays we don't use as anti-anginal drug. What is the bad thing? Let's discuss this. So for example, this is the coronary artery. And for example, in this area the obstruction is there, means the atherosclerotic plaque is the form here. So now the more and more blood need here, because the less blood is coming in this area, and this area is the suffering ischemia. Ischemic, this is the ischemic zone. So actually due to increase the adenosine, what will happen, even in a non-ischemic zone, because this area is healthy, so obviously this area also dilating, but along with this area, this non-ischemic zone, this area also dilated. And finally result, what would happen, the lot of blood will come this area, it should be go in this area, because the ischemic area in this area, ischemic, the formation of the ischemia in this artery, but due to dilation of the all artery, the blood becomes shift from there to here, and it can lead to even more worsen, because in these conditions here is the more blood need, but due to the non-ischemic area dilation, and the blood shifting from the ischemic area to the non-ischemic area, and it can lead to the severe ischemia, and it can lead to the become more worsen, or it's a very dangerous conditions we can say. So sometimes myocardial infarctions can be occur, or but it's depend upon the situation, and it's depend upon the obstruction. So in some time also lead to the cardiac death. Due to this reason, the dipyridamole nowadays we don't use as an anti-anginal drug, or we can say as a in instant cases, in a urgent cases we cannot use this drug due to this reason, and this reason is called the coronary still phenomena. So this name is still phenomena. Actually this name is that the dilation of the ischemic area, along with the also it's dilate the non-ischemic area, and blood shift from the ischemic to the non-ischemic area, and it can lead to the even more worsen, more decrease the oxygen and blood, and can lead to the infarction, and severe problem can be there. Due to this reason we don't use nowadays. But obviously this drug, and it has very potent coronary dilating effects, so that's why this drug we can use in a post myocardial infarction, or we can use in the mostly we can use in a post MI, because in post MI it has anti-aggregatory effect, so it's a more helpful for the in a we can say in a post MI. Now we'll discuss about some other drug, that is the trimethazidine. So let's talk about trimethazidine. Trimethazidine, first of all, actually what this drug is doing. If you talk about the mechanism of the action, so usually our heart, let's talk about the all normal general body, that all body it's by the energy, it's an energy source, it take from the glucose, but in the heart the energy take from the fatty acid. So actually it's inhibit the fatty acid oxidation. And how it will be helpful? Inhibit fatty acid oxidation. So normally, like for example, our brain as an energy source, it's take from the glucose, but the heart it normally it's take from the fatty acid, oxidation of the fatty acid. And for the oxidation of the fatty acid, the more oxygen requirement. So for the oxidation of the fatty acid, oxygen demand is the high, very high. But in the glucose oxidation, even in less oxygen, it can be minus, or it can be produce the energy. That's why those heart who suffering from as a anginal plaque or any obstruction is the in a coronary vessels. So on the time we need decrease the oxygen demand, because they already heart suffering from the ischemia. Already the oxygen is uh, going very less due to the obstruction. So and oxygen is carried by the blood, so blood is going less, so obviously oxygen will be go less. That's why we need to decrease the oxygen demand. Due to this reason, if we will inhibit the fatty acid oxidation, that is the major source of the energy, so again heart will taking from the glucose. Because now the fatty acid oxidation is inhibited by the drug. So obviously heart required energy by any way, by any source. So then after the inhibition of the fatty acid, then it will start to take energy from the glucose. And as we know that the glucose is for the energy production, it will take less oxygen than the fatty acid. That's why if we will inhibit the fatty acid oxidation, then even in less oxygen, they can we can say get the energy from the glucose. That's why this drug is the used for the as an anti-anginal. But if this drug is not for the acute attack, we can use as a chronic angina for the prolonged usage. About this drug, about the indication or as an anti-anginal, the main indication. Then about the side effects. Actually, we are not discussing very details about this drug because this drug is the alternative drug. So usually the first line of the drug, or we can say typical drug, that is the nitrate, beta blocker and calcium channel blocker. But this drug also we have to know, because in some conditions, for example, if the such drug is a contraindication, for example, calcium channel blocker is a contraindication or beta blocker is a contraindication, on the time for the minors we can use this drug. That's why we just important thing we are discussing. So side effects, most probably dizziness, headache, vomiting. These are the common side effects. And also sometimes flushing, because it's inhibiting the fatty acid oxidation. But flushing is not there because it's not dilating the artery. And some authors say that by the using this drug reverse the Parkinson's disease. So reverse Parkinson, but it's a very rare, but most side effect, and this side effect is a tolerable side effect. The patient can be tolerated very easily. Now let's talk about some other drug, that is the ranolazine. Actually the ranolazine have same mechanism. It also inhibits the fatty acid oxidation, but this is the secondary characteristics. The first characteristics are different. So let's talk about. And side effects you can add also, like the discomfort in the stomach, so gastric discomfort, but it's a common, so even normal dose patient can be tolerated. So we can say not severe side effects. Okay, let's talk about other drug. Ranolazine. The first, it also take part in the inhibition of the fatty acid oxidation, but it's a secondary, not primary. Primary is it's inhibit late sodium current channel. Actually, what is the late sodium current channel? This is the we can say that during the depolarization, the first phase means the first phase is the sodium potassium channel is the open and sodium will go inside, and then cell become depolarized. After that, open the calcium channel. But after the instant, we can say initially, after the initial they start the depolarization. So once the any cell become depolarized, after the late sodium channel current will be, it's a maintain the depolarization, or we can say prolongation of the depolarization. So maintenance of the contractility, maintenance of the calcium will be proper amount of it's coming from extra to intra. So for the maintenance or for the prolongation depolarization, this is the help the late sodium channel current. So by the ranolazine, it's inhibit the late sodium current channel, and it can lead to the decrease the cardiac or reduce the heart work. Because if we will decrease this one, so depolarization will not prolongation, it will not we can say prolonged depolarization. So obviously if that cell become not prolonged depolarization, automatically the calcium channel or calcium which is coming from extracellular to the intercellular, and working of the calcium become slow. So contractility always obviously become decrease or reduce. That's why this mechanism, one mechanism is the inhibition of the fatty acid, and second mechanism is the hair. So by this way it can lead to we can say reduce the heart rate, and it will be helpful for the angina patient. So by this way we can use. One thing also, that trimetazidine and ranolazine, the inhibition of the fatty acid oxidation, it is the helpful for the diabetes patient. How it's helpful? As we know that for the metabolism of the glucose we need insulin, but here due to inhibition of the fatty acid oxidation, the heart is now taking energy by the glucose, but without insulin. They directly oxidation by the glucose because inhibition of the fatty acid. So in these conditions, who patients who suffer from diabetes mellitus as well as also angina and some other cardiac diseases, or some other like antihypertensive, like the hypertensive patient, on the time if we will use trimethazine and ranolazine, it will be very helpful, because this one side it's reducing the cardiac problem, and second side it also reducing the glucose level. So it's much helpful for the person. That's why this two drug is the typical for the those types of person. Okay, about the indication, as I said that the most indication is the for the chronic angina. Then side effect, almost the trimetazidine the same, but some side effects, because it's also late in the sodium channel inhibitor. So side effect can be postural hypotension, then headache, nausea, vomiting the same, and also like vision problem are seen. Vision problem. And one thing also, that actually this ronella gene usually metabolized by the cytochrome CYP3A4. Cytochrome P3A4, these are the enzyme which is metabolized this drug. So those drug which inhibit this enzyme, it can lead to the accumulation of this drug in the body, and it can lead to the severe side effects. So those drug, for example, like some antifungal drug, for example ketoconazole and itraconazole, this drug is to inhibit this. Then some antihypertensive drug also, which I discussed in a previous video, that is a diltiazem. So diltiazem, it also inhibit this enzyme. So for example, if you giving the diltiazem, on the time you cannot give this drug, or it's absolutely contraindication. Or maybe you giving this drug, so on the time you have to inhibit or you have to skip this drug. You can select the other drug, because if you give the both drug, so this drug will inhibit this enzyme and can lead to the accumulation of the ronella gene, and severe side effects can be there. The ivabradine also metabolized by this enzyme, so that's why the same contraindication for both this drug. Let's talk about now last one, ivabradine. Actually, ivabradine have very interesting mechanism. This drug is the inhibit the funny current channel, which is situated in the heart, and it act like the beta blocker. Actually, it's not act in a beta blocker. It will not involve any in a beta blocker, but it's a one channel is there in the heart. For example, this is the heart. This is the SA node. So as we know that SA node have automaticity. It have automatically to depolarize without any stimulation. Then it has also beta 1 receptor. So whenever stimulate the beta 1 receptor, it will be stimulated. Except this through these two feature, the another feature have funny current. The name is the funny current. Funny current. Or we can say pacemaker current. So this feature, so this ivabradine is inhibit this funny current. Actually, funny current, it's mainly act on the SA node, and it's act like the beta 1, but it not involved in the beta 1, but it's act like the beta 1. Actually, This drug will be somehow inhibit the SA node, the function of the SA node, and it can lead to the decreased cardiac output because SA node have pacemaker of the heart. So if we will inhibit the SA node by any way, by the calcium channel blocker or by the beta 1 blocker or by the funny current, so it can lead to the decrease the or reduce the cardiac functions. So this drug is inhibit the funny current and lead to the decrease the cardiac output. So this is the another mechanism, but this drug also nowadays used for the chronic angina. About the side effects, almost the same. So, and also it's metabolized by the cytochrome P3A4. So that's why this also have to we can say manage, or we cannot give those drug who is inhibiting CY3A4 along with this drug because it's absolutely contraindication. Okay, so now we discuss all, I think all anti-anginal drug which are very important to know. Now let's summarize that how we can maintain. So first, a stable angina, vasospastic, and then unstable. First of all, for the stable angina, obviously nitrate are common. Nitrate is the common. In 3 of the nitrate we should give, but most probably it's helpful for the stable. In a vasospastic it will not too much helpful because it's a spasm of the artery, but also this drug will be help because in somehow it can be dilate. Then unstable also it will be helpful obviously because it's mainly dilate the vessels. So as we know that why, if we dilate the venule, it can lead to decrease the preload and obviously cardiac output will be decreased, which I discussed already. The same thing here, it will not too much dilate the artery, but in some percent can also be dilate and can also be lead to or helpful for the person. In unstable, obviously in unstable we need to more dilation because it's a completely or very highly obstruction of the vessels. So in unstable also nitrate will be help, but in a high amount, and we cannot in unstable persons we cannot use in outpatient clinic. We have to use in hospitals or intensive care unit because very dangerous conditions. Next drug, beta blocker for the maintenance or for the prevention of the nitrate side effects. Then calcium channel blocker also we can use. Calcium channel blocker. After that, we can also out of this drug, if for example if calcium channel blocker is a contraindication or beta blocker is a contraindication, so we can use trimetazidine or ranolazine, but dipyridamole we cannot use. Why? Due to the coronary still phenomena is developed. That's why. In nitrate, in a vasospastic is the best drug is the calcium channel blocker. Because the calcium channel blocker is mainly dilate the artery, and especially the third generation, that is the, like for example amlodipine, nifedipine, this drug is the very helpful. But on the time, for example nifedipine is the amlodipine, nifedipine, all types of dipine is the dilating the, and it's not acting on the heart, it's dilating the arterial smooth muscles. So we can use calcium channel blocker with the beta blocker. For example, diltiazem and verapamil we cannot use because diltiazem and verapamil will act mainly on the heart and some percentage also in arteriole. But we can use beta blocker and the calcium channel blocker of the third generation, that is the amlodipine. So amlodipine will be dilate the vessels, but if dilate the vessels, it can be reflexive tachycardia can be occurred due to compensatory mechanism. So on the time we use beta blocker for the prevention of the tachycardia or reflexive mechanism. So by the combination with these two drugs can be used or it can be helpful for the person. Now we'll discuss about another drug. We can use also beta blocker we cannot give here, just give for the prevention of the tachycardia or prevention of the reflexive tachycardia. So but it will not help to dilation of the any arteries. Then in the unstable angina, actually in the unstable angina, as I said, that is a very dangerous conditions, occlusion or completely blockage of the uh, lumen of the coronary area, or where is the obstruction is there. So in these conditions also we can use nitrate, but very high dose and in the hospitals only. Then calcium channel blocker, obviously we can use beta blocker also for the prevention, for the uh, reflexive tachycardia management. Then anti-aggregatory, anti-platelet, like for example aspirin and some other drug. Then anti lipidemic, which maintain the uh, lipid in the body, like the lipid metabolism, for example stannin and some other drug. Then also it require oxygen. Then symptomatic therapy, and most probably this types of patient care in the hospital and especially in an intensive care unit. So by help of this drug we can just we can say increase the, or we can say just suppress the or prevent the attack in some day or some month, but we cannot we can say completely cure. Obviously in this condition we instant need, if the occlusion or if the obstruction is the completely blockage, so on the time the we can say instant need the surgery, bypass surgery, or we have to put the balloon. For example, this is the artery and this is the, for example, completely the blockage of the artery by the atherosclerotic plate, that is unstable. So in these conditions we have to put the balloon here, that is the angioplastic, and by the balloon it can, all the aggregation will be stuck in this balloon and can be evacuate outside, or we have to put this area to clear of the lumen. So need the bypass surgery or angioplasty, or we have to put the stent. So this information about the unstable. So we can say the unstable angina we can just prevent, or we can say just for the 2 days 3 days for the month, for the prevention to the next attack. But before that we have to do surgery, bypass surgery or angioplasty. It's mainly for the unstable angina. But in the vasospastic and for the stable angina we can use as a we can say prolonged use or chronic angina, that is the called chronic angina. So in the chronic angina we can, by the help of this drug and some other therapy, we can prevent to further like 1 month or maybe 1 year, maybe 2 year. But in unstable cases we have to do very fast. So I think this all information about the anti-anginal, that is the we already discussed. So hope you will understand and you will like our videos about the anti-anginal. So till then, take care. Thank you so much.